Welcome to Kids Matter. I'm Dr. Elisa Minkin. As a pediatrician, mom, and grandma, I understand how challenging it can be to help our kids grow into their best selves. We are so much more powerful together. Here, I will be sharing the knowledge and wisdom of a wide range of people who understand and care deeply about children. I'm hoping for your input as well, because kids really do matter. They are our future.
Welcome back to the Kids Matter podcast. I'm really honored and really excited to have Dr. Esther Rollhaus here with me today. Dr. Rollhaus is a reproductive adult and child psychiatrist in private practice in Riverdale, New York, and via telepsychiatry to New York and New Jersey. She has particular interests in women's mental health, infertility, and pregnancy loss, and peripartum mental health. A sought-after seeker, Dr. Rollhaus translates complex, clinical, and research topics into accessible, practical content for a range of audiences. She has taught medical students, trained interdisciplinary healthcare teams, and presented at conferences, community events, and professional organizations. Her continuing education course, Hormones Are the Headline, is now available on her website, which I'm going to link in the show notes, childandfamilypsychiatry.com, and you can look into online courses on that website. So this is really important. I've been looking for a reproductive psychiatrist ever since I started working on the topic of perinatal mental health disorders with the perinatal mental health therapist in my community, Danielle Mizrahi, whose second episode is actually coming out tomorrow as I record this today. So by the time people hear this, 2 episodes will have been released, but I needed to speak to a reproductive psychiatrist because it's a different lens. I really needed that lens. We could not talk about, for example, the role of medication. And it's still, even putting aside medication, your lens is still a different angle that I needed to capture. I'm going to link to the show notes also my first interview with you, which is for the Jewish Orthodox Women's Medical Association, or JOMA podcast, called Women Are Not Just Small Men, on all the hormonal changes through the woman's lifetime. We are specifically focusing on what we are now calling matrescence. I did not know that was a thing, and we'll talk about that today. But I'm really excited to be talking about this with you. And I want to just start with having people understand what is a reproductive psychiatrist. And by the way, thank you so much for doing this with me.
My pleasure. I'm so glad to be here. And I had such a good time when we talked on JOMA. And it's really great to be here. I listened to the episode with Danielle Mizrahi, and I was in the car by myself, and I was like shouting out this. So
and you're going to love the second one.
Yeah. Oh, good. I'm so excited. So reproductive psychiatry, it focuses on the brain and the hormonal system, specifically through changes in a woman's life. So thinking about estrogen and progesterone as it affects the brain through puberty, through monthly cycles, through pregnancy loss, through preconception, pregnancy, postpartum, and perimenopause. And all of these are periods that happen to women that don't happen to men. They don't have these changes, and historically, psychiatry, which has been run by men, has neglected this part. And we've been thinking about neurotransmitters historically. But now, as people are specializing in reproductive psychiatry, we're really starting to think about the roles of estrogen and progesterone on brain health and brain functioning.
It's a great short explanation, and I mentioned matrescence, but I didn't define it because I wanted you to, please.
Oh, okay, amazing. So this is a term that came up in the 1970s and then has recently been reclaimed by Lucy Jones. I have her book, by the way. I brought a couple of books with me that I've been reading since I heard that we were going to do this podcast. We can link these in the show notes also. But these are amazing.
Rattled and Mom Rage, for people who can't see. Rattled, Mom Rage, and Matrescence. I'm going to write them all down.
And Matrescence. Oh, they're amazing. And they're really bringing to light the experience of new mothers and thinking about becoming a mother as a developmental milestone. So we've heard of adolescence. That's the period of transitioning from being a child towards becoming an adult. And what has historically been neglected is that there's actually a developmental process in birthing an individual or in becoming a mother. And that's an identity shift. That's a change in the way that society views you, the way that you view yourself. It's an opportunity for tremendous growth and sometimes an opportunity for growing pains, for significant growing pains.
Significant growing pains. So we're going to start with what's normal. By the way, I just read another book I don't know if I'm going to link it or not, called Momfluenced.
Oh, I like that.
The author of the book, maybe I will. The author of the book had postpartum depression, and there was this image of her online at night watching those trad wife, like in their gauzy gowns, and they're milking the cows with their beautiful children. And she's sitting there at night pumping milk because she can't directly breastfeed in the middle of the night. The pump goes whoosh, whoosh, whoosh.
Yes.
And that image will stick with me. Like the difference between how it's being portrayed right through social media, for example.
Yeah.
And how it is in real life. So I want to start with what we call the baby blues, because that's normal. We need to talk about what's normal, and then we need to get to where you need to seek help.
Yes. So the baby blues are normal, and they're a direct result of the hormonal changes that come from the decrease, the very steep drop of estrogen and progesterone. So essentially, a woman is almost going through menopause overnight, where she has the highest physiological levels of estrogen and progesterone she's ever going to have at the end of pregnancy. She gives birth, and they plummet down almost to a menopausal level at that point, over 24 to 48 hours. And we know that estrogen and progesterone have receptors in the brain, and they affect the neurotransmitter systems like serotonin, norepinephrine. And so we're actually going to see mood changes for everyone during that time. So about 80% of women have what we call the baby blues, which is tearfulness, moods up and down, feeling this overwhelmed feeling, which is both hormonal and also a result of taking care of a new life that is so overwhelming. I'll also say that I don't think we prepare women for birth enough. I think a lot of people go into this and they think of holding the baby and that feeling of almost like romantic love with the baby. Birth is bloody. Birth, it can be traumatizing. It can feel really out of control. I'll say that I remember having this experience of, oh my gosh, I'm leaking out of every orifice of my body. I'm sweating from the perimenopause. The milk is coming in, crying from my eyes, meaning like there's something a little bit more gory, I think, than how we portray new motherhood in society.
I must entitle this "Enjoy Every Minute."
Oh my God,
people say.
That's my pet peeve phrase. Enjoy every minute. That it's a really okay if you're not enjoying every minute. We just got to get through this part. We really do, and then that puts a lot of pressure on people, I think. And this idea that you're going to fall in love with your baby immediately, that doesn't happen for everybody.
I really wonder about protective factors to not go from, which is what we're going to talk about next, is actual perinatal mental health disorders.
Mm-hmm.
I wonder what you think about that, because one of the things she mentioned in Momfluence is she felt that the lack of support, I think not to mention lack of support, but definitely the social media expectations had an impact on her actually having postpartum depression as opposed to just the baby blues.
I want to divide it into sleep and the physiological measures that people can take, and psychosocial support, and then the cultural piece as well. So in terms of the biology, I would say sleep is the most important medicine we have. And often women are not getting enough sleep because they're the primary caregiver at night. They're either nursing or feeding at night and don't have support. And that 3 a.m. loneliness can be devastating, in addition to the fragmented sleep. So in general, to function optimally, we're looking for at least 5 to 6 hours of consecutive sleep.
But that can't happen if you're breastfeeding.
No, I know. And you have to feed the baby every 3 hours. And so I
want to say something before I lose my train of thought.
Go for it.
This is how I helped my second daughter who had a baby. I said, you sleep and we're giving a bottle. And I think if you're thinking about breastfeeding and the perfect parenthood, you never give a bottle and your milk has to come in and you have to nurse on demand. And she is doing really well with the nursing. She's so happy she's been able to nurse, and she almost gave up. And so there's nothing wrong with taking that step back and getting that sleep that you're been so deprived of at that point. Just saying.
Yeah, no, and it helps the long-term outcomes for the most part. Right. And so this isn't against breastfeeding. There are lots of benefits to breastfeeding, but a flexibility about how you're doing, whether it's a bottle, whether it's dad or somebody else bringing the baby to you at night so that they can feed from your breast, but you're not the one putting them back to sleep or the one who's changing the diaper at night.
Your sleep is still being disrupted if you don't take a break at all from nursing. And the point that I was making is you can still nurse even if you take a break at some point. You may need the break more than you need that particular nursing session.
Yes, agreed. Agreed. So sleep being so important and needs to be protected, especially for people who have a history of mental health difficulties. That is one of the number one things that I talk about in terms of postpartum plan. So people have birth plans, throw those birth plans out. You need a postpartum plan. How are you managing this?
I never heard that. I love that.
Yeah, and we can talk more about what that looks like. The other thing is the psychosocial support. So that's amazing that you go to your daughter and you help her sleep, right? And so somebody else taking care of some of the responsibilities over the 24-hour period. So let's say mom's up at night. Okay, but dad does morning shift, or grandma comes and she helps mom take a shower. That can't be underestimated in terms of the power of just helping mom eat, sleep, shower, just like basic hygiene, all of those important things.
This is why you need a village, and I feel for parents who do not have that relationship, say, with their mother who can come help them, Absolutely. Who do not have money to pay for a doula or a night nurse.
Yeah.
If you can, though, I do think that Americans are fiercely independent and think they should be able to do it on their own.
And I think that's one of the lessons of matrescence, actually.
Yes.
Right? One of the developmental milestones in becoming a mother is going from an individual person who can take care of themselves to having the experience of, actually, I'm limited. I cannot do everything that's expected to me all at one time. And actually being able to accept help can actually be considered a developmental milestone.
They don't tell you that.
Yeah.
I love this idea of the postpartum plan. Can you?
Yeah.
I don't know if you went through all the things. I don't want to interrupt you. You said
I'll
sleep.
do one more. So society.
Okay.
Society. Right? And this is where the issue becomes much larger than any one family, where women are being told to go back into work, sometimes 2 weeks postpartum, even 6 weeks postpartum, 8 weeks postpartum if you have a C-section, right? You're lucky to get 2 months. And in terms of like lactation access, right? This is incredibly difficult to be able to be a new mother and to go back to a profession or career or job so soon after having a baby.
But again, it's a matter of privilege, right?
I know, it is. It is.
To be
everything
honest.
Everything we're saying, my recommendations are get a doula, have breastfeeding
Right.
support, have a mother who takes care of you. These are all, you're right. You're right.
So I'm going to say as a counterpoint that sometimes you have to just accept your reality and make decisions based on that. And however pro breastfeeding I am, it might be to not breastfeed so that you can get sleep, so that you can go back to work. It might be.
Yeah.
We have, thank God, in our country, safe formula. Again, I'm not anti-breastfeeding, but we have to be more pro-mom than we're being already.
That's right. And better mom does, better baby does. And so I think
Exactly.
there's a dichotomy sometimes, or false dichotomy that people make of, are you prioritizing mom or are you prioritizing baby? Of course, we're going to choose the new baby. But no, that's a false distinction where really the outcomes of mom predict the outcomes of babies. So how well is mom doing really can influence how well the baby does.
Absolutely. And I don't know if you want to talk a little bit about the perfect parent trap that I alluded to when I talked about momfluenced, because I think we just keep having to say that we have to put aside all societal pressures and be very careful with the messages we're getting from social media, because it's this concept of intensive parenting right now, where the mother is just chopped liver and is expected to throw herself on the altar of motherhood no matter what.
Yeah, and this
It's
historically
so
hasn't been this hasn't been how it's been historically.
Right.
So we parented in groups back in the day, and there was a lot more support for women and fewer expectations, right? So the idea that mom needs to go onto the floor and play with baby, that wasn't there in the 1950s, right? Mom was taking care of the laundry and the house and those kinds of other things. I'm very pro going onto the floor with baby, but we have to understand that comes at a cost of something else. There are only 24 hours in a day. And so thinking about the expectations that filter into motherhood, I actually put on my website a journal entry that people can fill out, which helps them reflect on what's a good mom and what's a bad mom in their minds. Because when you think of what a bad dad is, someone who abandons the family, right? But what's a bad mom? Oh, she didn't pack lunch. She gives them chicken nuggets for dinner. Right? These are the societal messages that we get of what it means to be a good mom or a bad mom in our society. and the expectations are just too high.
It is a book, Bad Moms, by the way, but there's not a book, Bad Dads.
Exactly.
Enough said on that. You want to talk just for a few minutes about your postpartum plan, because I never heard that before, and I love that. And that, to me, anticipating the issues and being realistic, I think is so proactive.
Yep. So it's about sleep. What's your plan to get sleep? And it could be napping during the day. It can be, like we said, having more support at night. But how are you going to preserve your sleep? That's really important. And then a feeding plan of how are you planning to feed your baby? And I always tell people of plans are just that, they're plans. Okay? And we don't know all the factors that are going to influence what actually happens. And so if a woman has trouble breastfeeding, she can get support, she can get encouragement, but it is not a failure to not breastfeed your child. And I think so many moms feel guilt. I've seen so many moms start off their postpartum depression and anxiety episodes with breastfeeding difficulties. And sometimes if we know that someone's at high risk for PMADS, which is postpartum mood and anxiety disorders, sometimes we'll be very proactive about our recommendations of whether to breastfeed or not, depending on the circumstances.
It makes so much sense. And the basic idea is think about this before it happens, right? Is forearmed. Mm-hmm. So I really do want to talk about actual disorders.
Yeah.
So let's go into them. That's what we came here for, actually.
Sure. So
prevention, an ounce of prevention.
Yes. Let's talk about them. PMADS is the name for what used to be called postpartum depression. PPD, that's postpartum depression, has been in the literature, has been talked about since the 1990s, the 2000s, but PMADS adds in the anxiety component. So that stands for perinatal mood and anxiety disorders. So the perinatal piece adds in that it's not just postpartum, that we have hormonal changes that start in pregnancy, and depression and anxiety and other mental health conditions can actually start in pregnancy and are the biggest predictor of postpartum issues. So if somebody is struggling in pregnancy with depression and anxiety, they are at higher risk for struggling postpartum.
Absolutely.
Yeah. And then
and also if they had them before, even before they became pregnant, that's a whole separate.
That's right. That's also very, we should talk about that also.
We should, especially because that's where you come in.
Yes, that's where I come in. Yes.
To have a reproductive psychiatrist, we're going to say that.
Yes, it is. So then the mood and anxiety disorders piece. So it's the depression piece and the anxiety piece. And generally they come together. Almost invariably they come together. And what does that look like? For postpartum anxiety, it can look like checking a lot on the baby, having difficulty sleeping when the baby is sleeping, intrusive, obsessive thoughts about harm coming to the baby. Postpartum depression, what distinguishes it from the baby blues is a sense of lack of joy, lack of connection, difficulties with feeding yourself, sleeping, with those kinds of important, functional outcomes. Sometimes people have somatic symptoms, so body-based symptoms, and so they'd be like, why am I not feeling well? I'm feeling dizzy all the time, or my stomach hurts all the time. And those can actually be symptoms of PMADS, where there's nothing physically wrong, but the distress is manifesting in the sensations of the body.
Absolutely. And anxiety, by the way, I think my experience is that anxiety is actually more common, and that's an issue I have with screening and pediatricians are supposed to, and we do in my practice, screen for, it's not really PMADS, it's really more of postpartum depression, and we're missing the anxiety that I find to be more prevalent and still very concerning.
Yeah, and in society, we're still talking about postpartum depression, and people will come in and they'll say, I feel fine. I'm not depressed. I'm functioning. But on the other hand, I also can't sleep. I'm these kinds of intrusive, catastrophic thinking, overthinking, those somatic symptoms that we talked about, that is under the umbrella of PMADS.
Exactly. So I think that's really important. I wish that the screening took that into account.
I know. I think people are working on it, to be fair. I think that there is more of a push towards that, and so I think the field is trying to get more to capture the anxiety piece.
I'm also going to say that I'm seeing some resistance for various reasons to the parent filling out the screen. There's concerns for privacy. They're not really your patient. Mental health has stigma. And also sometimes the insurance bills for it, and they're like, I can't pay for this, so I don't want to have to pay for it. And I get all of that. And if you're one of those people, please tell the clinician what you're going through, because
Mm-hmm.
that was the whole point of screening. We have very little time, and it's hard for us to assess it. Topic like that without a screen. It's really much more helpful to have the screen.
And the pediatricians are the ones who actually really spend the most time with moms postpartum. They're going in, they're coming and having the well visits for their babies. Pediatricians are the ones really to pick it up.
Right. And what is first line treatment?
It's a good question. So usually it's psychotherapy. So usually you can go and you can have there are lots of evidence-based psychotherapies for PMADs. What I recommend is that people go to specialists in this field. There actually are reproductive therapists. So people who specialize in this that I recommend reaching out to. And PSI, which is Postpartum Support International, has a whole listserv of therapists that specialize in this.
Let's link to that. That's really important.
So
I
important.
believe I linked the first episode and not the second, but really important. But when you say a specialist, Danielle Mizrahi is an example
That's
of
an
a
example.
therapist who has specifically been trained in perinatal mood and anxiety disorders.
Yes, there's actually a degree that I find very valuable. It's PMHC.
Right,
So,
she has that.
Yeah, exactly. And so when you see that after someone's name, that's a good indication that they've trained and been certified specifically for mental health issues related to women, hormones, and postpartum.
And I'm going to bring up that there's a couple of access issues here. Finding a therapist that has the specialty, just like finding a reproductive psychiatrist, being able to afford it. A lot of therapists, especially specialized ones, do not take insurance. And then the time, right? You're sitting there, you're already sleep deprived. How are you supposed to have time for that? Throwing that out there.
Yes. I'll say one thing that kind of emerged from the pandemic that I think I'm grateful for in terms of access, which is now states with telehealth, now states that historically haven't been able to be accessed are able to be accessed by psychologists through something called PsyPact, where when you're licensed in one of the PsyPact participating states, that actually extends to about 30 other states. So that's wonderful. I'm gonna give an example of New Mexico. I hope that's one of them. Like you're licensed in New Jersey, you get your license in New Jersey. Now you can reach New Mexico through telehealth. That's an example. And a lot of women prefer telehealth with their new babies. It's so hard to get out of the house. And I'm a huge proponent of telehealth for new moms.
Absolutely. And you should ask your insurance, and you should make your insurance cover this, because we're supposed to have mental health parity.
Yes, we are. Yes, we are.
So besides therapy, what else do we have in our toolbox? What do you have in your toolbox?
So I have medication. And what I'll say is that coming to see me does not mean that you're going to get a prescription. That's okay. It can just be a conversation. Reproductive psychiatrists are also experts in diagnosis. And sometimes having a expert tell you, listen, what's going on for you? This is PMADs, right? This is something that we know, it's biological, it's very real for you. Sometimes even that conversation can be helpful for people. Yeah, go ahead.
Sorry. I wanted to know who should get medication. That's my next obvious logical question.
Right. So people for whom psychotherapy is not enough, people who are having functional disturbance, meaning that they're not able to do the things that they need to do. In the postpartum context, that's sleep, when the baby is sleeping, take care of themselves, nourish themselves, eat, get out of the house, have social relationships, attached to the baby, have excessive ruminative guilt. These are all signs that we need to escalate treatment. And medication is it's indicated for moderate to severe symptoms. And so you might even start with that even before psychotherapy. So if somebody can't participate in the psychotherapy because of how severe their symptoms are, then actually medication is a first choice. That's where you would start.
It's a really important point, because I do see a lot of parents trying desperately not to go on medication.
You know, and it's the indicated treatment. It's the indicated treatment. And if we understand this is biological and neurotransmitter mediated, then it makes sense that that we actually are targeting what is like the biological factors there. And so I know that there's a lot of stigma about medication, a lot of hesitancy, and a lot of guilt, frankly, about taking medications. And I want to explain to your viewership really like what this really means. What does it mean really to take medications? So for the most part, when we talk about medications, we're mostly talking about SSRIs, which are selective serotonin reuptake inhibitors. And they work on the brain to create more of the neurotransmitter serotonin. They're not making more serotonin, but they're preventing the cleanup of serotonin between the nerve cells. Okay, so that there ends up being a net increase in serotonin. And what we find is that they're very effective in reducing anxiety, reducing intrusive thoughts, and reducing depression. And they really work. You have to be on them for long enough, and you have to be on the right dose of them for them to work, but they are incredibly effective in treating PMADs.
That's great summary. And I want to point out that you can go to your OB and get a prescription in terms of access. I want your thought on who needs to go beyond the level of the OB, because OBs cannot handle the entire spectrum of the PMADs.
So your GP can do this, your OB can do this, and often what they'll do is they'll start a low dose of medication, monitor, perhaps they'll increase it, but for the most part, they'll stop at a certain point, and people might need higher doses or may have more complex issues, and that's where you want to go to a reproductive psychiatrist. So if the symptoms are getting better on, I'm going to say Zoloft 50 or Zoloft 100, and the OB is not comfortable continuing that, as makes sense because it's not their area of specialization, then reproductive psychiatry can really very much help. I'll also say we're talking about anxiety and depression, but anybody with a bipolar spectrum illness, in my opinion, should be at a reproductive psychiatrist.
Exactly.
It's not the same disease, and it carries a lot of risk for postpartum issues, especially postpartum psychosis. And so that needs expert care for sure.
And that's before you become pregnant.
Yeah, to start with a reproductive psychiatrist. Yeah.
Right. I think if you already have a significant mental health condition and you're already on medication before you even become pregnant, it's really helpful to consult with a reproductive psychiatrist. Is that across the board, though? I would say if you just had mild anxiety and depression, that wouldn't necessarily require that.
I think you can acknowledge that it actually does put you at increased risk for postpartum depression. So even people who have had mild anxiety and depression in the past are at increased risk for PMADs compared to people who have not had any mental health history. That being said, often what happens is that they can go through the pregnancy and either it works out like super well, or there is a relapse, or there are symptoms, and then at that point they can come to a reproductive psychiatrist and work on those symptoms.
Again, it boils down to access, right?
I know.
In the ideal world, you would do it because you want to be proactive and you don't know what's going to happen, even with the milder end of the spectrum of mental health concerns.
Yes.
But certainly for something like bipolar or a previous history of the more severe end of the PMADs, right?
That's right. Yes, and I want to mention a couple of things. One is that PMADs also includes other conditions, including perinatal OCD, perinatal PTSD, and postpartum or perinatal psychosis. Those are also other diseases that fall under PMADs. So if I can say one moment just about perinatal OCD. So that is where people are having intrusive, obsessive thoughts that can't go away, and they often do something like a compulsion to try to mitigate the anxiety, but the anxiety can't be mitigated, and it keeps going in a cycle and a cycle. So a really important fact is that actually 80% of women have intrusive thoughts, not related to OCD, just related to the peripartum changes in the brain, where we're actually going to see loops and thoughts that can come in. And these thoughts can be highly distressing. They can be about harming yourself or harming your baby. They can be very graphic sometimes with images. People can actually see themselves harming their babies. And that is not pathological. That is an expected change in matrescence for the most part. Where it becomes a disorder is when it's persistent and when the person can't move on from it. And so they are thinking and then they start to do avoidance behaviors. So they can no longer hold the baby because they continue to visualize dropping the baby. And then they're avoiding caring for the baby because of these intrusive thoughts. That's where it becomes problematic.
That is incredible that you laid that out, because Danielle and I did talk about that, and she recommended the book. I think it's called Real Moms Have Scary Thoughts.
Mm-hmm.
Which I'm going to link. I'm going to link a whole library.
And Karen Kleinman has done amazing work on this field. And really bringing this to light. And it's very important for providers to understand the normal intrusive thoughts and the OCD intrusive thoughts and distinguish that from something that's dangerous, like something like thoughts of harming the baby from something like postpartum psychosis.
It is. And I see that as the role of a therapist to be able to really sit down because, again, clinicians do not have enough time to suss that all out. We don't, right? Except at the level of distress of the parent. If you see there's a certain level of distress, right?
I think sometimes reassurance, though, can be helpful, even in just for someone who doesn't have OCD but is having intrusive thoughts. Sometimes reassuring them that this is normal, right? That this happens to people. It doesn't confer a risk, any increased risk of actual harm coming to the baby. Sometimes that actually in itself can be reassuring, just having that psychoeducation.
Right. Pediatricians, we're really good at saying normal. Normal. We can do that. And that's why what you said is so incredibly important.
Right. Because for most of the people who are seeing you, it is normal, right? If that's the statistics, 80% of people coming to you and sharing these scary thoughts, you can reassure them.
What's a quick way to know that they're in the normal zone, though, for, say, a busy pediatrician?
I think understanding their level of distress, of how often they're thinking about this. So is it taking over their lives? Is it leading to avoidance behavior? Are they doing some kind of compulsions like checking to make sure, maybe perhaps assessing whether they're going to harm the baby over and over again? Those kinds of things cue you into that it might be something more than an isolated intrusive thought.
Someday we'll have a more comprehensive screen than the EPDS, which is the depression-focused screen that we have right now, because time.
Yes.
Okay, so that's a really big problem. So I want to talk more about medication because there is resistance. And I do think that resistance falls into two categories. One is the resistance of taking it during pregnancy because no one wants to take any medication during pregnancy if they don't have to. And one relates to nursing. I think we're going to have to put nursing on the back burner today because I don't think we're going to have enough time. But I definitely want to talk about taking it while pregnant. And if we can get to it while nursing.
Sure, we'll try. So I want to distinguish between people who are on medications before pregnancy and people who need to be on medications starting in pregnancy. So essentially a new onset PMADS or perinatal disorder, or the many people who are on SSRIs for anxiety, OCD, depression going into the pregnancy. The data on the pregnancy and on the drugs are the same, but the advantage of the people who know that they're coming in on an SSRI can benefit from a preconception consultation. So they can actually meet with somebody, talk about the medications, talk about the risks or benefits, sometimes optimize the medications before we're going into a pregnancy. I think you said no one wants to take medication if they don't have to. Yes, agreed, if they don't have to. But what we have to do is we have to weigh the risks of taking medication compared to the risks of not taking medication. And in many cases, we're talking about tremendous suffering from the symptoms of depression and anxiety that actually we know have negative impacts on the pregnancy themselves in terms of obstetrical outcomes and in terms of actually some of the epigenetic changes that we see in fetuses who are exposed to the stress hormones related to anxiety and depression in mom.
Feeling stressed just thinking about stress hormones.
Yeah, cortisol, it's a tough one. It's a tough one, and it really can change some of the epigenetics.
Do not Google people. Okay.
No, don't Google. And this isn't meant to be to blame anybody. Right. So I can see somebody who's listening to this and they're like, I'm anxious, and now I'm messing up my kid by being anxious.
You can't win. You can't win.
You can't win.
But you know what, though? What I meant by don't Google is there's a very strong anti-medication thread going around, and it's the current administration's people are not helping, not to mention names.
That's right. There was a whole panel.
It's very problematic. Studies are coming out and people are saying this is dangerous. Medication is dangerous and bad. And then the mother is like, what am I supposed to do? Is it cortisol or is it Zoloft?
There are a lot of studies that are coming out that are showing the safety of these medications,
right,
where the risks are incredibly low. And so what's challenging sometimes about assessing medications in pregnancy is our gold standard is something called a double-blind placebo study, where we have two groups, we give one an intervention, the other one doesn't get an intervention, and then we look at the outcomes. But for pregnancy, we have to do it retrospectively, meaning that we can't experiment on pregnant women of giving some drugs and some not drugs and then seeing the outcomes. We actually have to look at the outcomes in the children and then extrapolate backwards into whether the medication increased the risk of some negative outcome. So I'll give you an example. Let's say we wanted to look at the rate of pregnancy loss. We have to compare it to the baseline risk of pregnancy loss across all pregnancies, which is about 20%. what we see when we look at the moms who have been exposed to SSRIs is that it follows. It's about 20%. The same thing in terms of risks of malformations or birth defects. The baseline risk in any pregnancy is 3 to 5%. And reassuringly, when we look at the risk for babies whose moms have taken medications, it's tracking at 3 to 5%.
So we don't have evidence that it is not increasing the risk, which is good.
Yeah, that strongly suggests that, yes.
We don't know for sure, and I think uncertainty is something that is really hard, especially when you're pregnant and you're trying to do everything right.
I know.
But it's also a reality, and my recommendation is to not Google, find a clinician you trust, and let them help you make the decision, and then just do it, as opposed to trying to agonize, right, and to go into analysis paralysis and try to do that risk-benefit assessment yourself.
That's right. And so really what the psychiatrist should help you be doing is really talking about risk versus benefit. I like that frame, where what's the risk of the medications, and helping you go through all of the outcomes for the medications and comparing them to the baseline risk. Spoiler alert, actually, SSRIs seem to not increase the risk of any of the adverse effects that we can think of during pregnancy. You can get into the specifics of that, but for the most part, your psychiatrist should be able to explain to you the data that is essentially very reassuring on the SSRIs. They should also take into account your own history and the suffering and the distress and the functional disturbance that is occurring from the undertreated or non-treated mental illness. And then really emphasizing the benefit of women deserve to be, they're not incubators. They're autonomous human beings who need to function while pregnant and beyond. And so there's actually a lot of merit to thinking about how wellness can help somebody and help their whole community, help the baby. There's so much to that. Women deserve to be well.
You said so many great things. I don't know where to start. One is women are not incubators. And again, the societal pressure treats us like Madonna, right? Like we don't matter. We're the vessel. And that's not true. You deserve to be. Can we say that enough times? Louder for the people in the back. Number one.
Women deserve to be well.
Thank you. You are not chopped liver.
No, you're important.
So that's one thing. But another thing that I wanted to say about that was, so another thing is when you said risk versus benefit, that really needs to be underscored, because I think it's very hard, but it's true that everything we do has risk. So no one is saying that these medications are risk-free. You have to acknowledge the risks, because sometimes it's portrayed in order to get people to accept it as, oh, it's 100% safe. And then you wonder why we don't have trust.
I never use the word safe.
Right.
Safe is not the word.
Medications have the risks. They just have to be put aside compared to the risk of not taking it. And that is a very individualized decision. So to underscore again, in the age of not just Google, but AI, you really need to have a clinician walk you through this, because only they can help you take your individual situation under account. Not your social media friends, right? Not Google, not your family, not anybody else.
Right.
They don't have the objectivity and they don't have all the information.
And in the panel that we talked about from the authorities that we may or may not be referencing, the problem with it was that it didn't talk about the alternative of not treating. And so I watched the panel. I found it very scary in terms of these papers that are incredibly complicated and honestly misquoted or misinterpreted. But the clinical approach was not, or the clinical factors was not actually accounted for, in my opinion.
Wait, what panel? Sorry.
So this is from the FDA. So the FDA had a panel about safety of medications in pregnancy. And it really was a scary panel, and I can see how somebody would make conclusions to not take medications from it. But the problem was that it was skewed, and then it didn't talk about the alternatives of not taking medications. And it didn't talk about the suffering of women. It whitewashed what a PMADS experience would be like. Yeah.
It came from an anti-medication bias, okay? And that's why you have to be so careful. And I understand the concept of somebody who may feel that medications are being pushed by big pharma and don't trust the studies behind it. And I think that's why you have to have that individualized conversation. And the clinician has to work with you, because I find that some parents in my practice as a pediatrician are very hesitant with medications for their kids. And I work with them, but it does matter about the functional level.
It really
of the
does.
impairment. Yeah,
it really does. And the urgency with which somebody needs help. Sometimes we
Right.
don't have time to wait or to try psychotherapy. Like sometimes there is an urgency if the functionality is really disturbed, unfortunately.
But to flip the script on that, just like I do for a family, say the child has ADHD or mild anxiety, and we're doing accommodations in school and therapy, we're not doing medication, the same can be true for a woman who goes through this and goes to her clinician, and the clinician just prescribes medication, but maybe they don't need it.
And there is some non-thoughtful prescribing out there. And I can really relate and I can understand that that sometimes these decisions aren't well thought out.
Right. So trust your gut. When I say trust your clinician, you need to have that trusted relationship. And again, there's a certain degree of privilege that goes on here, right?
I know.
Because time is the general practitioners, the OBs, and the pediatricians' big problem or lack thereof. So we've talked about a lot of different things. I think we have a little time, if that's okay with you, to talk about breastfeeding and medication, because that is a separate conversation.
So what I want to say about breastfeeding is actually it's much more, I would say lower risk in some ways because the infant is getting much less of the drug compared to the actual pregnancy. So when it's placental transfer, the drug is going through the bloodstream and it's going into the baby's bloodstream. But lactation actually involves a process of filtration. And so the infant is actually getting very little of the drug. And so we look at something called the RID, which is the relative infant dose of how much of the drug is the baby actually getting. And we use 10% as a marker to really think about the amount that they're getting as almost negligible. And so most of the SSRIs that we're talking about are well beneath the 10% mark. And so the baby is actually not even getting that much of it. And then we also have to look at the clinical outcomes. And for the most part, babies are tolerating this just fine. It's one of the most commonly prescribed medications postpartum, and women are using it in lactation. And we're not seeing adverse effects like growth issues or anything of that sort.
That's really helpful to know. And there is a whole database, and lay people can also access the database. I think it's LactMed is one of them. I don't know if that you need to be a physician for, but there's also, what is the one that's free and available? Is LactMed free and available?
I'm not sure actually, but I access LactMed a lot. There's also mothertobaby.org, which also answers questions about medications in pregnancy. And so you can type in the specific medications and get reliable information about that. Mass General also has a wonderful website that's geared towards patients themselves, where people can actually look up the data on each of the medications, either in pregnancy or breastfeeding. And so there are some very reliable resources out there. The internet isn't all bad.
It isn't all bad. As pediatricians, we get these calls every single day. Can I take this while breastfeeding? And we're fine with those questions. We want to support breastfeeding moms with the reassurance that can be quite, not 100% safe. Nothing's 100% safe, but the risk benefit is in favor, and that's really good explanation. There are other medications that people with PMADs or pre-existing mental health conditions might be taking. Are the whole range of them, besides the SSRIs, safe while nursing?
So lithium is an example of a medication that is very controversial in nursing. And so I'm not going to say a blanket no, but that is something that would need to be coordinated with the pediatrician. The infants may need blood levels taken because they are exposed to lithium does get through the breast milk because of its chemical composition. And so that is more complicated. But for the most part, most of the drugs that we use commonly in psychiatry have very reassuring data.
That's really good to know. I'm also thinking about women whose conditions possibly could be exacerbated by nursing. Is that a thing?
Oh, yeah, it's a thing. Yeah, so we know about hormones influencing mental illness, and there are hormonal changes that come with nursing. So in addition to the sleep issues that sometimes can come with nursing, there actually can be hormonal changes. Studies have looked at whether nursing attenuates PMADs, meaning makes PMADs better, or causes PMADs, and it hasn't been conclusive yet. But weaning, we know, actually can be a time of increased risk of PMADs. So if somebody has been nursing, their hormones have been stable to some extent, they wean, especially if they wean suddenly, the hormones decrease, almost mimicking the postpartum period, and you can actually see an emergence of symptoms upon weaning.
Wow. And that's because I'm thinking that the flip side is nursing can actually help mental health disorders.
That's also true, right? That's also true. And that's why the data is somewhat controversial at this point. We don't have a clear recommendation about nursing or not nursing from a hormonal perspective. But I will say that if it's interfering with sleep, if it's causing a lot of distress, then that is a factor in which someone could consider not breastfeeding.
And I've seen plenty of parents who are really struggling to nurse, and then they're not sleeping, and then they're anxious. And for some of them, just saying it's okay to not breastfeed will save the whole mother's mental health, and it helps the baby too, for the mother to be.
Yes.
It's so obvious, but I feel like I need to say this. I had a mother many years ago who said to me, I will be always grateful to you for giving me permission to not nurse. And again, I'm pro breastfeeding, okay? But the individual decision is so important. So one thing could just be lack of sleep and anxiety because breastfeeding is not going idealistically, right? I want to just take a minute to talk about something called DMARE. I didn't put it on the list, but I just thought of it. Since we're doing okay on time.
Sure. Yeah. Dysphoric milk ejection reflex. So that's the experience when the experience of the letdown of the milk causes a tremendous distress and dysphoria. Yeah.
What to do about that?
That's a tough one. I'm actually not 100% sure, but I think that sometimes might be an indication to stop nursing. I don't know that there's actually an intervention that we can make pharmacologically for DMARE at this point. That being said, it might sometimes be tolerating the dysphoria, understanding that this is physiological, and so some psychoeducation can be helpful for DMARE.
Is it transient or is it longer lasting?
I think it depends for the individual woman. And so it's really usually when the milk is let down. So at the beginning of lactation, when the milk essentially comes out of the breast, that's generally when the dysphoria occurs. Generally it resolves over the feeding, but it can last for the duration of breastfeeding.
That's unfortunate. I'm going to have to look into that more because I don't know either. But
yeah.
So another possibility is to not breastfeed exclusively and to do a combination of breast and bottom. I'm thinking of ones who mothers don't have enough supply, right? She's tried a lot of things, or she has to go back to work and she can't pump.
Yeah, I really find this often, and sometimes in the stories of the onset of PMADs happens around nursing difficulties. And the mom is feeling like a failure, feeling guilty that she's not producing enough milk, keeps trying everything, and really there's so much wrapped up societally in the pressure to breastfeed, unfortunately, that she feels like a failure. And sometimes that in of itself can lead to rumination and guilt and lead on to PMADs. And so I really try to take the pressure off of my patients.
And we have to be very careful because we've been promoting breastfeeding so aggressively, and it's a double-edged sword. Yes, we're pro breastfeeding. I'm not. But I see this a lot with parents the mothers come out of the hospital and they have had it thrown at them. You must breastfeed. Don't give a bottle. Don't give a pacifier. Don't do this. Don't do that. And then they come home and the milk's not in, and it just starts what I call the downward spiral.
Yeah. I've seen it many times. Yeah.
So I think that planning the feeding beforehand, not just in terms of your mental health, but even just having the mindset of, I'm going to try, I'm going to get as much support, but I'm going to be okay. If it doesn't work, it will not be my being a failure.
Very much. And coming into that. And that's part of the postpartum planning, is that these are plans, but these are not cemented. You have to take into account the actual reality on the ground.
It's absolutely true. We could go on all day, but I know you have to go back to work, and I want to let you go. But we're going to link to a library.
Yes, there's so many resources out there. I just want to say people are not alone, and it is not your fault. It's not your fault. It's a real thing. It's really biological. Nobody is to blame for PMADs. And there's lots of help out there.
Absolutely. And there's also a wide range of what's normal that no one has told you about, but we just did.
Yes, that's right. Exactly. It can be a really difficult and distressing time, even when we're not talking about on a level of disorder. And so both are true.
We do not expect you to enjoy every minute. That should be taken out of the vernacular.
No. And fall in love with your baby right away. No.
All normal. All normal. Thank you again so much for doing this with me.
My absolute pleasure. Thank you so much for bringing this really important conversation to light. Really appreciate it.
Thank you for listening to Kids Matter. Raising healthy, happy children takes a village, and I'm grateful you're part of ours. If today's conversation resonated with you, please share this episode with another parent, grandparent, teacher, or anyone who cares about kids. Together, we can build the supportive community our children deserve. I'd love to hear from you. Share your thoughts, questions, or suggestions for future topics at kidsmatterpodcast@gmail.com with no exclamation point. Your voice truly matters. Until next time, keep advocating for the children in your life because kids really do matter. They are our future. I'm Dr. Elisa Minkin, and this has been Kids Matter. Please note that while I am a pediatrician, I am not your child's pediatrician. This podcast is for informational purposes only and does not constitute medical advice. For any medical concerns or decisions, please reach out to your child's healthcare professional.